Thank you. We move to the next session, and for that, I invite Dr. Amit Soni, Dr. Chandrakant Usendi, Dr. Shobha Nanja as moderators, Dr. Sihas Lele, Dr. Naveen Agrawal, and Rajesh Toshani as chairpersons, and we have an interesting session on Hocm. I request chairpersons to introduce our international faculty and my new friend, Professor Srihari Naidu. It's a pleasure having him here. He's probably the highest alcohol septal ablator that I know from my circle. And it's a pleasure to have him. And I also have a surgeon who's going to be talking about Dr. Mehul Shah. So chairpersons, please introduce our speakers.
So first of all, is a very nice conference by Dr. Kamal and Cardiacon 2022. I invite Dr. Srihari Naidu from USA, and he will be presenting in case of Hocm regarding a septal ablation by alcohol method. So we are proceeding with him. He is a medical director of cardiac catheterization laboratory for Hocm, and he is a former resident of New York Hospital, and he is a professor of medicine in New York Medical Science. So I invite Dr. Srihari Naidu to start.
Thank you. You can unshare your screen, then you want to introduce the surgeon? I'll go ahead. Okay, thank you everybody for inviting me. Kamal, I've never been part of this conference. I've heard great things, and I'm very proud to be here, so thank you for the invitation. You guys can hear me? Okay, yes. Good. So I'm going to talk about alcohol ablation for this patient, and the patient that was described is this young man who's 44 years old with clear HCM with significant obstruction, 22 millimeter septum, clear class 3 symptoms with class 2 heart failure, and severe provocable gradient and typical MRI and EKG findings. So with HCM, it's very clear that once you have obstruction, as you see here in the middle, after an indolent phase, you get all these problems. So the patients go from relatively asymptomatic to mildly symptomatic to profoundly symptomatic due to congestion, heart failure, intermittent syncope, and a higher risk of sudden death. Alcohol ablation or myectomy can mitigate this by interrupting this cycle and decreasing obstruction, decreasing symptoms, and decreasing LVH. So the question is not whether this should be done, and all the guidelines suggest that these should be class 1 indications in these patients. But the real question is, what is the safest way to get the same efficacy and the same survival? I've been doing alcohol ablation for a long time. My first one was 2002, first one on my own, 2004. And I've been involved in multiple textbooks and the guidelines, as well as a training course, proctoring people, traveling around to help people learn this procedure and launch it at their institutions. And then if it's done right, alcohol ablation works quite well. You take patients with severe gradient, provocable Brockenbrough maneuver, and you take them to a phase where there's no gradient, and over a course of about 3 months, this can completely resolve and improve the heart failure state. And you see by echo, this is a 1-year echo on one of my patients. You see the mid septum is still a little thick, but the basal septum looks like a pure surgical result. Wide outflow tract, normal mitral valve. And this patient, you can tell, will have an amazing result and go on for many years with no heart failure, without surgery. Alcohol ablation, of course, then has been performed for about 25 to 30 years now. It avoids general anesthesia and intubation and sternal incision and healing, maintains the clinical benefits of surgery when done well, and has reduced costs in all the studies and reduced length of stay. Patients in the hospital 3 to 4 days. Surgery is also quite good and perfected at centers of excellence, been done for a longer time, but of course you require a sternotomy, intubation, associated morbidity, and there's more complications, especially as patients get older. There's a lot of good data now for alcohol ablation. This is the largest registry in the United States, showing that 95% of patients end up in class 1 or class 2 NYHA. So these patients do quite well and go on with their life. There's a low mortality, less than 1%, and pacemaker rate has come down to about 6.5% due to all these innovations that you see there. And in all the studies that we've done so far, and this is from the Cleveland Clinic, showing equal survival as well as functional improvement. From Duke, also showing survival is the same for alcohol ablation or myectomy. And in fact, when you adjust for confounders and comorbidities, the alcohol ablation survival rate is actually better than surgery. And even when you look at Mayo, which was a proponent of surgery for many, many years due to a high volume and preference for surgery, they find the survival rate is the same with myectomy and alcohol ablation, even if they selectively take the lower risk patients for myectomy and the higher risk patients for ablation. The survival at 8 to 10 years is exactly the same when matched for age and gender. If you look at long-term survival and other meta-analysis for all-cause mortality, 1.5 versus 1.5, basically for alcohol ablation versus myectomy in terms of annual mortality after these procedures. And for sudden cardiac arrest, it's 0.4% for alcohol ablation per year and 0.5% for myectomy per year. So there's more and more evidence that they're at least the same, if not better, for alcohol ablation. Now, in these large centers of excellence, there are some differences you see. When it's done well, there's still a higher pacemaker rate and redo rate with alcohol ablation, but the mortality rate starts to favor alcohol ablation. And I think I would beg to tell you that patients would rather be alive than have to live with a pacemaker or a redo rate like angioplasty. So in centers of excellence, NYHA class improvement is the same. More than 90 to 95% of patients get to class 1 or 2. Long-term survival is the same. Pacemaker and redo rates may be higher with ablation, but procedural mortality may be higher with surgery. Now that's centers of excellence. When you go to the real world, and this is a study that we published in 2016 in the Journal of American Medical Association, we found that in the real world, things are very different. Death rate is actually much higher with surgery than alcohol ablation. Pacemaker rates are probably about the same in the real world. Stroke is worse for surgery, bleeding is worse for surgery, and renal failure is worse for surgery. And this makes a lot of sense because these are morbid procedures. And my suspicion is there's probably some reporting bias in the large surgical centers, or they're just so good at reducing mortality and they typically don't report these other aspects of surgery. So in the real world, procedural mortality risk is higher with surgery. Pacemaker rate is probably the same. And there's more stroke and renal failure with surgery. And we know this from the angioplasty versus surgery literature too. So it's not a surprise. We then published this year. This is from my group in the NIS data looking again that surgery has a higher, this is stratified by gender. Surgery has a higher mortality than alcohol ablation. But interestingly, all the pacemaker risk is in the women with getting alcohol ablation. Men actually have a very, very low pacemaker risk, much lower than even having surgery. And again, in the real world, you see surgery has about an 8 to 9% pacemaker rate across the board, not the less than 2% reported in the Centers of Excellence. So death again is lower with alcohol ablation. Pacemaker rate in the real world is actually 9% with surgery. And actually pacemaker rate in men is probably 3 to 4%, is much lower than in women. So who is the best surgical person? This is somebody who is less than 21 years of age, massive LVH, mid-ventricular obstruction with or without an aneurysm, concomitant surgical lesions, membranes in the outflow tract, anomalous papillary muscles, or absence of acceptable septal perforators. Ablation can be done for everybody else. These are older patients with comorbidities, those with particularly perfect anatomy, such as this patient, pre-existing right bundle branch block, and patients who understand the risks and benefits of both, qualify for both, yet favor a more percutaneous approach. So the verdict is clear in this patient. Alcohol ablation is preferred. He's male. That's a low risk of pacemaker of 3 to 4%. The septum is less than 25. We can get that septum with alcohol. There's a good first septal perforator to that septum. There's a lower pacemaker rate compared to women or surgery overall. Lower procedural mortality than surgery, lower cost than surgery, lower length of stay than surgery, same functional improvement and same long-term survival. Thank you very much.
Thank you, Dr. Naidu. And we are proceeding with Dr. Mehul Shah. He is an eminent and most reputed cardiac surgeon of Ahmedabad city, and he's working with Apex Hospital, and he did his study from Ahmedabad and postgraduate and super specialty also, and he was attached with UN Mehta Hospital, and now he's a consultant in Ahmedabad in Apex Heart Institute. So we are proceeding with myectomy is a surgical aspect in case of HOCM.
Hello friends, I am going to talk about the surgical aspects of, let me first briefly introduce the operation septal myomectomy. 1 in 500 of general population has HCM, and around 70% of these may have variable degree of obstruction. That is why treatment of such common pathology is very important. Surgical myotomy was done as early as in 1958. It was Dr. Andrew Morrow who standardized and popularized the surgery in 78. Later, few modifications were done by Dr. Mesmer in 94. At present, we are doing transaortic extended myomectomy. Let me discuss the physiological effects of septal myomectomy. First, there is immediate drop in the pressure gradient after surgery. This is the immediate effect. In response to reduction in the pressure gradient, there is improvement in the systolic function in the free wall. Later, there is regression of LV hypertrophy that improves the diastolic function. Moreover, there is reduction in LV mass greater than that attributable to surgical removal. The SAM disappears, MR regresses, there is reduction in LA size 2. All this correlate with increase in functional capacity and improvement in mmHg class. More importantly, this translates in survival benefit after septal myomectomy. Talking about the advantages of surgery. Surgery is safe, predictable, and durable. It is a physiological treatment that has a potential to offer a cure. The mortality rate today is 1%, and complication rate is around 2 to 3%. After surgery, there is long-lasting relief from obstruction, and there is very low reintervention rate of about 1 to 2% versus 15 to 25% after alcohol ablation. These are the various reports quoted in many international publications. There is minimal residual gradient of 0 to 10 millimeter after surgery, while up to 30% of patients after alcohol ablation have gradients of 30 or more. This can predispose to fatal arrhythmias. Some more advantages of surgery: low incidence of requirement of permanent pacemaker after surgery, around 3.5% against 9 to 15% after alcohol ablation. There is greater improvement in mmHg class after surgery than alcohol ablation. Septal myomectomy is more effective in treating thick septum and severely symptomatic patients. Residual obstruction after alcohol ablation are best treated with surgery. Concomitant mitral valve pathology can be easily corrected during surgery. Mid-ventricular obstruction is best tackled by surgical resection. I have to mention this high-risk group. Patients coming for surgery after unsuccessful alcohol ablation fall in high-risk group. They have higher incidence of complete heart block, cardiac failure, and even higher mortality. That is why, in first place, young patients should be treated with surgery as primary treatment to avoid such an outcome. Who are not suitable? Now, elderly patients with comorbidities like those with risk of severe stroke, bilateral pulmonary disease, and those in whom cardiopulmonary bypass is contraindicated are not suitable for surgery. I have to share a concern. At present, only tertiary centers are doing most number of cases across the globe. And even there, numbers of septal myomectomy are falling. Most busy centers doing 30 to 50 cases a year. Septal myomectomy is a specialized procedure and results are operator dependent. So concept of super subspecialization should be applied to it. More and more surgeons should take interest and expertise this very effective gold standard operation. I conclude by saying that though there is no difference in hospital mortality between the two procedures, surgical treatment is superior in long term. Therefore, surgery should be the preferred treatment. Our patient is young with a high gradient, severely symptomatic. I would certainly like to operate on him. Thank you, Dr. Kamal Sharma, for giving me the opportunity to present this.
Thank you very much. Fantastic talks, Professor Naidu and Dr. Mehul Shah, both of them are master of the subject. Over to chairpersons and moderators for the questions. I would just try to trigger a discussion. Wouldn't be the clinical profile be deciding factor in choosing what to do for the patient? Because we know now how elderlies would behave as compared to younger ones, how a presence of an LBBB pre-existing would make a case more for, say, myomectomy, or say RBBB pre-existing, and you do a myomectomy, you end up with a complete heart block, actually. So wouldn't the clinical cases per se scenario beyond what has been mentioned here would actually be helping us in choosing the therapy? We now know that the need for pacemaker is less for, say, a good myomectomy compared to, say, alcohol septal ablation. Recurrence rates may be more with LV function issues. I would like to have your comments on that. Professor Naidu first, and then Dr. Mehul.
Yeah, sure. So, obviously I did my presentation to stimulate discussion in the debate, but in our practice, we send about 60% of patients for alcohol ablation. The other 40% I take them through myectomy. So we have surgeons who do that. And we have a heart team approach where all the patients are presented and we discuss. I think that in general, I usually send patients less than 45 or 50 to surgery. However, it really depends on anatomy. If the anatomy shows that it's a very focal LVH of the basal septum and a good septal perforator, and there's not much more thickening, there's nothing wrong with the mitral valve like in this patient, and there's not a whole lot of fibrosis, which I think is very important. You have 15%, but you don't have 25, 30%. These patients usually have obstruction as the main etiology of their symptoms, and if the alcohol ablation can get that out of the way, they go back to class 1. So a lot of it is about predicting which patients will have the best efficacy. If you have a young patient that has massive hypertrophy, 2.5 to 3 centimeters that extends more distally to the base of the papillary muscle, that's an area where there's so much obstruction, and there's also concomitant diastolic dysfunction, both because of cavity size reduction as well as the fibrosis. Those patients do better with surgery. So it really depends on those factors and not a one-size-fits-all. So age alone is not a cut point. I agree with the pacemaker issues in terms of pre-existing bundle and branch block. Obviously, we will send some of those to surgery routinely because the pacemaker rate is much less. And on the opposite side, some of them won't get surgery because the pacemaker rate is too high in that situation. The last thing I'll comment on is I've done almost 300 alcohol ablations. I've not sent one, none of them have gone for surgery. And I can say that confidently because compared to Mayo Clinic and Cleveland Clinic, where patients get lost to follow-up because they don't live locally, all my patients live locally. I mean, I'm in Manhattan. So I have the 3 states, 25 million people. I follow all my alcohol ablations for 15, 20 years. I know if they need more ablation, if they have to cross over to surgery. On the flip side, I've done up to 10 patients who've had myectomy who need an alcohol ablation. And so it can go both ways. I think it really depends on the expertise of the facility. And oftentimes those anecdotes drive what they believe in terms of which ones are better.
Mehul bhai, your comments?
Yes, I agree with you, Kamal. Each patient is different, and we have to do what is best for that particular patient.
Chairpersons, we have Dr. Thoshani is a cardiac anesthetist. So I'm sure he's there for both the cases. I mean, if he's to come for myomectomy or he has to myectomy or for alcohol septal ablation, you'll keep a cardiac anesthetist standby. So how do you think how these patients do behave?
Yes, most of the time the role of anesthetist is very important in case of surgery is concerned because assessment of septal thickening, we are using transesophageal echocardiography and we are assessing how much surgeon has to cut because there is high chances of formation of ventricular septal defect if you are doing an over enthusiastically resection. So this part is very important. After coming off bypass, you have to check for the proper dissection is happening or not. Is there any LVOT obstruction? What's the gradient? So these are the parameters. If we can look properly, then we are giving a best add-on treatment to the patient in post-operative outcome.
We have
I would like to mention that.
Go ahead.
Yeah, I would like to mention that we have to have a transesophageal echo. Without that, if we don't have, we can't do the surgery.
Right.
Yeah, in the surgical suite, they have TEE, and we use isoprel. We go 1, 2, 3, 4 of isoprel before we start cutting, and we go back to the same dose that provoked the severe obstruction after the procedure to make sure that everything is gone away. I've insisted on that because I've seen at other institutions patients come back with more distal obstruction or problems with the mitral valve, and so we make sure that all that obstruction is gone, and they are heavily dependent on TEE as well as the anesthesiologist to make sure that happens. Yeah. On the flip side, we don't use anesthesia.
I think mavacamten is available in US. We don't have it in India. Are you seeing, is it the statin of HOCM? We see a lot of statins actually bringing more acute coronaries in cardiology. Does mavacamten does change the gradient or symptoms that much that it's going to be the so-called statins of HOCM?
Yeah, so let me answer that. First, I want to answer the question that we don't use anesthesia and alcohol ablation. My patients are awake. They get a little bit of morphine, but I talk to them the whole time. So they're wide awake. The risks are much, much lower in that situation, and you can really provoke good gradients when they're wide awake. So that's part of the reason I can affirm that the gradients go away, because they're not hidden by the anesthesia. Second thing is we were involved in the mavacamten trials in Valor. Valor will be presented as a late-breaking clinical trial at ACC 2022 in about 6 weeks from now. This is a trial comparing mavacamten versus placebo, standard of care in patients who are already selected for either myectomy or alcohol ablation. And the primary result at 6 months is what percentage of patients still qualify for septal reduction therapy at 6 months in the mavacamten group versus the placebo group. I know the results, but I can't say the results. So those results will be out, and it is supposed to be simultaneously published in the New England Journal of Medicine. We're hoping for that. We have not heard that yet. In the preliminary studies, though, mavacamten does appear to, in the phase 2 studies, decrease the LV outflow tract obstruction significantly. It is difficult to titrate. You have to be careful and go up slowly in these and echo guided. So they're not officially available in FDA yet. We're hoping in second quarter, but the full trials will come out. Now, in the preliminary data, it looks like myectomy and ablation increased the peak VO2 on CPET by about 4 to 6 points, whereas mavacamten in those trials have increased at about 1.5, which is very similar to exercise and losing weight. It's not to say that those medications aren't strong, because most people can't exercise and lose weight, but they will do at least that benefit. And the real question is that enough to get the threshold down to SRT? And that's what the trial is going to show us. But I do think that most patients are benefiting from it. The question is it benefiting enough? Will they prefer an oral agent versus a more permanent cure, as Dr. Shah mentioned, and whether there are any long-term hazards to these medications?
The chairpersons, moderators, if there are any questions, Dr. Naveen?
Yes, Kamal, I can say that this is only surgery where anesthetist can insist the surgeon, you should not go beyond this point. This is only surgery that anesthetist can suggest to the surgeon not to go beyond this point.
It is a difficult surgery. We're also doing more apical myectomy. I don't know, Dr. Shah, are you doing those there? We see more and more midventricular obstruction with apical aneurysm, and we know the aneurysms can cause scar, they can cause thrombus, they can cause arrhythmia. So I'm pushing my surgeons to do apical approaches, or both apical and transaortic approaches, reach through the midventricle, get rid of the, tie off the aneurysm and see how patients do. And we've had about 10 of those patients, not many, but they've so far done well over the past 4 or 5 years.
Yeah, I think all my patients that Dr. Mehul has operated, he's gone transaortic, and I mean,
transaortic, yes.
None of them had a VSR, so
yeah,
that's the good
thing.
But
I think that some of these midventricular with the ballooning apex, he might want to start going apically for those patients and getting rid of the aneurysm. We've had good results in young people. Older patients fall apart, but in the young patients, they seem to do well.
Yeah.
Moderators, Chair, if there is anything, Dr. Amit, Dr. Shobhanan, if you have any comments.
I will address also, if I have some time, the issue of education. Dr. Shah mentioned this, that it is declining volumes for surgery. I think that's true. I think that the problem is that there's few centers who do it, so those places have to train it. And 30 to 50 a year may not be enough to train somebody to go out somewhere else and do it, so it becomes challenging. I don't know what the solution is to that is, because I do think that we need both surgery and ablation. Yeah. I know there's no question. I don't offer my patients a choice usually. I usually decide which one's better for them. And if it is surgery, I tell them I'm going to get you through it, and you need the surgery, and this is it. And they usually trust me, and we go for that. And the surgeons are fabulous here. Dr. Spielvogel, Dr. Malik, and those two do all of our surgeries together with our cardiac anesthesiologist. So I'm confident about that. But I think the problem in surgery is that they're not going out and training. So I mentioned that I run an alcohol ablation course. I'm willing to go to hospitals and do their cases with them. And I think that's something that surgeons are busy too, but I think people have to do that. Oftentimes people are concerned about other people doing the procedures, but if we don't do that, then everything dies. And so we need to keep these things alive.
Yeah. Yeah, I agree with you. Yeah, that's right.
Dr. Amit, Dr. Chandrakant, Dr. Shobhanand, if you have any comments.
Sir, I would like to know, I have a question to Naidu sir, that is he using mavacamten in post-alcohol septal ablation patient?
So right now it's not approved outside. So I haven't used it in anybody in the real world. I've only used it as part of the clinical trials, randomized. And those patients are not allowed in the clinical trial. That being said, I think it can be used for patients who have residual gradients after either surgery or alcohol ablation in the future, off-label. You know, I will tell you that I know that historically alcohol ablation gets this issue with more residual obstruction, but you know, really it's about planning, just like surgery. You can tell which part of the muscle needs to be ablated. I don't have any failures. I mean, you can come see. I've been doing it for a long time. And, you know, I teach my fellows, they rotate through the practice as well. And then you can't lie with alcohol ablation and myectomy because every single patient is being read by the echo lab. If it's not being done right, I'm going to hear about it very quickly, and the program won't grow. So these procedures do well, and but it has to go to the right people. I think one of the challenges in the real world, as I showed you, is it's not as good in the real world as it is in centers of excellence. I haven't had any of that, and we haven't had any VSDs for surgery. It really has to do with volume. And I think that's why if it's done in the best places, you can truly choose the right procedure based on the operator's expertise and decision-making of a heart team and expect the appropriate result without having to have many crossovers. I feel a crossover is a failure. Surgery to ablation is a failure. Ablation to surgery is a failure. Redo is not a failure because I oftentimes will purposefully not do as many septals, hoping that I got enough without having to use a pacemaker. And I'll come back in 6 months to a year to do a little bit more if I need to. And the combination of the two separated results has a lower pacemaker rate than doing both of them in the same sitting. And so I offer that to the patient because it's a better safe result and lower pacemaker risk, even though people may criticize that I have to redo. But redo, you know, we're all interventional cardiologists and we do redos. Redo is not a problem. Patients never complain about a redo alcohol ablation. They've had it once, it's not been a big deal.
So how small a septal is not worth enough, you know?
Oh, that's a good question because people think that the septals are small. Now we know from CTOs that these septals are long and they can go all over the place. So remember, the septal is not just the distribution of the septal. It's a lattice network in the septum. If I take a small septum and give more alcohol, I will diffuse into the neighboring area of the septum through that lattice. So you don't need to have a large septum. You need to have a septal to that area in the right location, and then you can give as much alcohol as you want, depending on the timing. I mean, obviously you need to have a balloon in there. So you need a 1.5, you know, a 1.015 like that. At 1.5 probably is the lowest you can do. But oftentimes you give a little intracoronary nitro and the septum is larger than you think. And then you can reevaluate.
Thank you very much. Thank you. We had a very wonderful and lively learning session here. So I think we had a wonderful session. I would thank from my bottom of my heart, my friend, Professor Sri Hari Naidu and Dr. Mehul Shah and all the chairperson and moderators for this wonderful session. Thank you very much. Stay connected and hope to see you, Professor Naidu, soon, sometime, maybe next year physically in the conference here in India.
Thank you.
Take care. Bye-bye. Thank you.